to something. I would think it's probably something neurological in origin, or then apart from that, it's probably some other kind of thing which I think psychogenic probably, or due to any other reasons. So up to this point, I do not have. I only have a few things that I'm considering. Maybe if we hear more history, that can help me see if I can come close to what is really happening with the patient.
Okay.
So history.
Yeah, sure. So it was also difficult for me when she told me that. And so let's hear the HPI. Can you now hear me well?
Yes, yes.
Yeah. So this was a 51-year-old female who was apparently well until 1 month ago. So she told me 1 month ago she was throwing a stick with her right hand to chase away a cat, and she felt abrupt onset of electric shock-like sensations on the right side of the face. The shocks came in paroxysm, were sustained for 1 to 3 seconds, and disappeared only to recur again after minutes to a few hours. The shocks are triggered by talking, chewing, opening the mouth, and sometimes even walking. And they doesn't involve the region above the right eye, and they disappear during sleep. They are so intense such that she cannot do anything when they start, and she denies mouth deviation, tingling, or numbness sensation on the face. She denies headache, visual abnormalities, hearing problems. She denies limb weakness or paresthesia, and she also denied altered mentation. She denies similar episode in the past. She also, because of this illness, she was prescribed pregabalin, 72 milligram once daily 2 weeks ago, but she doesn't report any improvement in her symptoms. So that's HPI.
Okay, can I see the first slide?
Okay.
Okay, so this is a 51 years old female who was apparently well, and the symptoms are about a month. So we are talking of something subacute here,
Mm.
but which seems to have started suddenly. Yeah, so that was a sudden onset, and it was triggered by something. Now, this history here that she was throwing a stick, and that was with her right hand, and then she experienced those sensations on the right side of the face. Uh, and they come in paroxysms. They are sustained for only a few seconds, and then they disappear and recur. These are triggering things. So I'm trying to think, because I have never come across such a complaint. I think people talking about shocks, I've come across those complaints, but then on probing further, you figure out something else. So for this particular case, it's the first one ever for me. So because I do not have a specific schema, and I do not have a particular pattern that I can recognize. So for this case, basically what I'll try to do is thinking slowly, and so that is using whichever tools that I have, the knowledge of anatomy, physiology, and everything that I can use in order to see if I can make some progress. That's what I'll try to do, because otherwise it's a completely new symptom. Because one of the things that I would think of is, if someone is complaining of some things, then you can have some sorts of neuralgias, but then the complaints many times they are different from this one at least. So for example, someone who had zoster on the face, for example, uh, sometimes later they will present with a burning sensation on the dermatome that was involved, and that's what we call post-herpetic neuralgia, but that is burning rather than, although yes, stinging or something sharp can be reported. So now that does not fit this pattern here, and what this patient reports is something that that happened suddenly after it was triggered by something. Now, if now trying to think in order to see if it can make sense neuroanatomically, for example, the sensory supply, because so these symptoms, the shock-like sensation, so that's an abnormal sensation, which is not common. We do not encounter commonly. But then, uh, what is going on? So, for example, if someone we have the so-called trigeminal neuralgia, and of course, the nerve that supplies or that innervates the face as far as sensation is concerned, the common is the trigeminal nerve, and the trigeminal nerve has the three branches: the ophthalmic, the mandibular, and the maxillary. So I see that the symptoms are happening below the right eye, I believe. So if we are talking about the specific branches of the trigeminal nerve, then most likely you are talking about the maxillary downward. So yes, I mean that with my limitations, I think I'll have to refresh my neuroanatomy as far as the trigeminal nerve and the innervation of the circuits in general around the face are concerned. But what I see here, this is an abnormal sensation, and therefore there is a possibility that the trigeminal nerve is involved. So are we dealing with trigeminal neuralgia itself? I do not have much details about it, but maybe that would be my best guess based on these symptoms. Now the question comes, what is the relationship between the activity that triggered this symptom to begin with, throwing something with the right hand. So the nervous innervation to the upper limb is through the brachial plexus, and the nerve roots for the brachial plexus are from C5 at least, C5 downwards. So from C5 all the way to T1. So there is no direct relationship with the trigeminal nerve, whose nucleus, I believe, is in the brainstem. So what exactly is going on here? Although yes, I know that the trigeminal nerve has a downward course. There is some interaction with the sympathetic nervous system or the sympathetic trunk, but then I do not see a direct connection between the trigeminal nerve and the brachial plexus. So I cannot exactly link the two symptoms. Joseph, your slides have disappeared. I'm not sure if you can bring them up again and see. But that's where I'm stuck right now. I think my best guess is it's something probably. If it has a neurological basis, then it should be a problem with the sensory innervation of the face, which is predominantly the trigeminal nerve. Yes. So can I see the? Okay. So this is the other slide, and these seem to be very intense, but otherwise no mouth deviation. So mouth deviation is facial nerve involvement. The patient denies that. No tingling, numbness, no headaches, no visual abnormalities, no hearing problems. So another thing that probably makes a little sense. Can you bring back the first slide? The previous slide. I remember something like, yes, triggered by chewing, by talking, opening the mouth. So yes, the motor part of the trigeminal nerve, supplies these muscles of mastication. So the temporalis, as well as the buccinator muscles and the lateral pterygoids, if not mistaken. So these activities that involve movement of the muscles, which are innervated by the trigeminal nerve, seems to be triggering those symptoms. So I think with lack of a proper a proper schema to approach this, I think that is my best guess that whatever we are talking about is probably involving the trigeminal nerve and most likely the sensory part of it, although hard to explain. So just the sensory part involved. Otherwise, the motor, okay, we'll see on physical examination, but turns out we haven't heard about any weakness, but we'll see on examination if the motor part is involved. So I think that's my best guess for now. Let's just see other components of the history in order to see if I can make any progress.
Yeah, that's a very good start, by the way. Well explained much of the things, and so to proceed. Retrieval system was unremarkable. Past medical history, she is non-hypertensive on irregular medications. Currently, the measures she has include candesatin H and pregabalin that was prescribed 2 weeks ago for this complaint. Family social history is unremarkable. Anything on that?
Okay, so uh, what maybe what is significant or what deserves attention is the history of hypertension. The patient is on irregular medications. Of course, what happened? What happened was abrupt. So it's something that came up very quickly. So now the exact pathology, because what I was talking about so far, I think it was just localization. Where exactly, and we cannot properly localize without physical exam. But then with the history, maybe something else that we need to think about is now what is the exact pathology? Is it a vascular event? It happened suddenly. So a vascular event is of hyperacute onset. So this was hyperacute, but then it was triggered by an activity. Now, is it a coincidence? But then again, with my hazy memory and knowledge, of course, of the neuroanatomy of the brain stem, where where at least most of the nuclei of these. And by the way, you remind me later, maybe if you read that the exact location of the nucleus for the trigeminal nerve. But then if we talk of something vascular, many times we actually, when we talk about something vascular, we talk about motor involvement rather than just sensory symptoms. And what seems to be significant here is sensory symptoms. So if it's something vascular, of course, hypertension on irregular medications, that could be a risk factor. But otherwise, I think, of course, before we say maybe before we say that medicine doesn't read books, I should admit that I have not read all the books. So I'm not sure if this is a CVA that only has a sensory involvement. But so the hypertension would link to that way. But then at least with what I've come across so far, that doesn't. Uh, if we are talking about something vascular, then it should be very atypical in that it's predominantly sensory involvement. The motor part, at least from the history, doesn't seem to be disturbed so far. So that's all I have from the other components of the history. Let's see the exam.
Sure. So the general exam, she was Latin oriented. She was a febrile. She had pupils which were equally reactive to light, and she was not pale. She was not jaundiced. She didn't have lymphadenopathy nor lymphedema. So when I was taking history, she experienced shocks after every 5 minutes or less, but there was no movement of the affected side. Vital signs: blood pressure elevated 172 over 105, pulse rate normal 75, respiratory rate 16. The temperature was 36.6 and she was saturating normally on room air. Neuro exam: her higher centers were normal, and examining her cranial nerves. So the right cheek was looked smaller than the left one. And when she was asked to balloon the cheeks, the left one was ballooned larger than the right, and she couldn't fully smile, as she said when she smiled fully she would trigger the shock, so she was scared of that. But she had intact sensation on the face, and but her other cranial nerves were normal. Her power were normal in all limbs. She had normal deep tendon reflexes. Plantar reflex was normal. Coordination normal, and sensorium was also normal. Other systems like the cardiovascular, chest, abdomen, and musculoskeletal were also normal.
Okay, so with this one, higher centers are normal, and then coming to the cranial nerves, so other cranial nerves were normal. All the cranial nerves, all the others were normal, except we see some findings which are significant here on 3 bullets. So the right cheek is smaller than the left one. And then when asked to balloon the cheeks, so you said the ballooning seems to be more on the left as compared to the right, right?
Yeah.
And then she can fully smile. So the muscles that are involved here, predominantly, I mentioned the muscles. Now I'm not sure uh, where exactly, because you reported that the right cheek is smaller than the left one. Okay, so there is a number of muscles here, and what we see seems that, of course, this could be a little bit confusing as far as interpretation is concerned. So ballooning cheeks, basically, when we tell people to balloon their cheeks, we are testing the muscles of facial expression, and that is the function of the facial nerve. Yes, that is the function of the facial nerve, ballooning the cheeks. Yeah, because there is the number, the muscles involved. So one of them being the orbicularis oris. Yeah, orbicularis oris, which is so that is the function of the facial nerve. So I'm wondering, uh, is the facial nerve also involved? Uh, and then, of course, from the history, you told us that the symptoms did not happen above the eye, which means only the lower half of the face is involved, most likely. So that is my assumption, that it's the lower half of the face that is involved. And so I hope even closing eyes against resistance, probably that was bilaterally symmetrical, with no differences between the two sides. So yes, I think if I take my time, and if I was very good with my neuroanatomy, this would have helped me to make a diagnosis, or at least localize the lesion properly. But then I'm not confident enough that my neuroanatomy is perfect to help me localize precisely. But then the way I see it, probably the facial nerve is also involved, given that the arguments I've already made. And then the right cheek being smaller than the left, I'm thinking, is this patient having atrophic muscles on the right? Is it the muscles of mastication? Maybe Joseph, if you can, are we talking about the cheeks laterally, or are we talking about the face in general? Where did it seem smaller?
The cheek, the the left cheek was a bit bigger than the right one. Like,
And on motor examination, when you're examining cranial nerve number 5, on palpating the muscles of mastication, the temporalis as well as the masseter muscles, were there any differences?
yes, so the on the affected side, they were smaller than the unaffected side, like a bit of atrophy.
Okay, okay. Yeah, so the muscles on the right seem to be atrophied. Uh, Now, so here is so this is something that I'm still debating in my mind. With ballooning of the cheeks, and maybe you'll teach me better later. But ballooning cheeks, I take it to be predominantly a function of the facial nerve, and so I'm thinking, is there some sort of facial palsy on the right also, and then the trigeminal nerve on the right also being involved? Uh, but then we are told that sensation on the face is intact. So which means fine touch, temperature, pain, they all normal. So I'm thinking these are I'm suspecting that the two nerves, the nerves on the right, it's either the trigeminal nerve by itself on the right is involved, and the facial nerve too. But then the other point that I'll try, because as I said, I'm doing slow thinking today, so I think I'll have to recall and even the anatomy of the facial nerve itself. So the facial nerve is one of those cranial nerves that are said to receive inputs from both sides. And for example, when someone has a stroke, so if it's supranuclear, because a pathology in the cranial nerves can be supranuclear, in which case we would equate it with upper motor neuron lesion, and then if it's infranuclear, then it's similar to lower motor neuron lesion. So the facial nerve receives input from both hemispheres. So if we are talking about a supranuclear lesion, we have weakness, because the difference will be whether it's the entire half of the face, or is it just the lower half of the face. So in one of the two, between supranuclear and infranuclear, you have just the lower half, and in the other one you have the entire half of the face. But then with two cranial nerves being involved, uh, suspicion of two cranial nerves being involved, that is the facial nerve and the trigeminal nerve. So a problem could be in the area where they are originating, and so many cranial nerves are around the pons, the medulla, so basically around the brainstem. That is where many of these are originating. So I'm thinking probably a pathology could be in that area, but now what exact pathology, still not sure. But being the fact that we had it was something sudden, then probably we should entertain a possibility that we are dealing with something vascular, because otherwise throwing a stick, just like I said, so if there was anything that happened, the upper limb is moved by the brachial plexus, which doesn't seem to be very much connected with these nerves. So I think I'm still around the same area. So what has been added is I'm considering a possibility that the facial nerve is also involved in a way. So any more details that you have in order to see if I can refine my thoughts?
Yeah, very nice. So labs were not impressive. Only she had a cholesterol that was at 6.9, but otherwise everything else was normal, including the ESR that was 20. Maybe if you need any other test which you think can lead to the diagnosis.
Okay, so And maybe something else that did you try to elicit the Georgic reflex?
No, I didn't.
Okay, because the Georgic reflex would have helped us maybe localize it further, because if it's exaggerated, then we could think what we are dealing with. But then, so maybe let's just come here. If when you see atrophy, when you see atrophy of the muscles, if I was talking about the spinal nerves, I would say the problem is from the anterior horn onwards to the peripheral nerve itself. So if you see atrophy of muscles supplied by these cranial nerves, then the lesion is most likely lower motor. Uh, I could be making a wrong assumption here, but most likely the lesion is lower motor. So commonly, I mean that would be something. It would not be supranuclear, but most likely infranuclear. Now, if we think about, so it's from the nucleus downwards, that's where the lesion is. Uh, is there a way we can test these nerves? I'm not sure if we have a special NCT for these cranial nerves. I do not think so. So I'm considering. I think for this patient, maybe, although now the symptoms have been protracted, they have been there for a month, but I would consider, I think I would just go and review, because I'm not exactly sure what is going on, but I would think about a possibility of imaging. So among the things that I would need to order, imaging would probably be one of those.
Okay, imaging of.
Yeah, so basically that would be imaging of the brain, but
Yeah,
particular focus will be the brain stem. So I think an MRI would do a better job here.
yeah, that's true. That's what I also ordered. And these were the findings. So it showed multiple punctate nodular areas of altered signal intensity in periventricular white matter and central valve, which were iso-intense on T1 and bright on T2 and flare. But there was no mass or periregional edema. There was also no lesion on the brainstem. The conclusion from the radiologist was Fazeca2 vascular encephalopathy with a DTX of the myelitic disease, and he advised clinical correlation.
Okay, now multiple punctate to nodular areas of altered signal intensity in the periventricular white matter. So there was because this when you are talking about the periventricular white matter, we are still very high up. So nothing was mentioned specifically about the brainstem.
Yeah, so the brainstem was normal.
Okay, okay. So these are multiple punctate to nodular areas, uh, vascular encephalopathy. Okay, so these are imaging diagnosis, but now how do we link these two things? How do we link these two things? So this is something that is seen in the CNS, and my guess was that we are dealing with something. So basically, infranuclear from the point of the nucleus downwards because of the atrophy. And no pathology was reported, at least in the area where the nuclei are originating. So I'm not sure what to make out of these. I'm not sure what to make out of these punctate areas which have been reported. If you talk about demyelinating diseases that I know, especially of the CNS. So you are talking of things like multiple sclerosis, Neuromyelitis optica is also demyelinating, and then MOGAD, monoclonal oligodendrocyte glycoprotein associated disease. I think those are the major ones that I can recall quickly. So multiple sclerosis, neuromyelitis optica, and then MOGAD. But then with multiple sclerosis, yes, the lesions of multiple sclerosis are periventricular, but then they are finger-like projections. They are known as Dawson's fingers. But then, yes, when I think about multiple sclerosis, I know multiple sclerosis does present with shock-like sensations. So I think that is something that I did not recall earlier. But yes, multiple sclerosis does present with such a sensation. But then now these lesions that are reported in the periventricular white matter, are they typical of Dawson's fingers? Maybe if I had seen the images, because I've seen some at least from online literature, not from real patients that I have attended. But then I would say yes, these look similar to Dawson's fingers that I've seen. So could we be dealing with multiple sclerosis? So multiple sclerosis has a number of phenotypes or patterns. They're relapsing and remitting. And then, so if we diagnose multiple sclerosis in this patient, we would struggle with one thing, because we would need to see, yes, imaging features of demyelination, but then you need to see lesions that are separated in space and time, which means you have demyelination in more than one area, and then you have demyelination at different time intervals, which I think we will struggle to establish here, because this seems to be the first presentation. This is the first time the patient presents with these symptoms, and then they have been, they seem to be paroxysmal for the entire month, and then we haven't seen anything else in another area, like in the spinal cord or any other area. So I'm struggling to say we are probably dealing with multiple sclerosis. A picture of neuromyelitis optica that I have is involvement of the optic nerve, which presents as blindness, and then they can also present with transverse myelitis. They can also present with a huge proportion presenting with area postrema syndrome, which we have noted in this patient. So I'm not exactly sure what to make out of this MRI, but I think now these demyelinating conditions like multiple sclerosis, I'll put them low on the list, but with reservations because of the caveats I've just talked about. Anything else that you have?
Nothing. Maybe you have to make a diagnosis.
Okay, so this is where you make a diagnosis. I think I do not have a diagnosis.
I think you have.
What I'm thinking of is because the clinical features that we have. So I did not see anyone who joined late, but then we've been having a 51 years old female who presented with a 1 month history of shock-like sensations on the right side of the face. And so these started suddenly after she threw a stick to chase a cat. And then they have been occurring in paroxysms. They come and last for a few seconds, 1 to 3 seconds, and then they disappear, come later. They are precipitated, or yes, they are precipitated by activities which involve movement of the face, like chewing, talking, sometimes even walking. So the physical examination for me was convincing I'm thinking that the trigeminal nerve on the right side is involved, and then probably the facial nerve on the right is also involved. And I'm thinking it's more of infranuclear, because we've heard that we have atrophy of the muscles on the right. So it's lesions on from the nucleus downwards, maybe the peripheral nerves themselves, the cranial nerves, and then uh, imaging was done, and then we see lesions which are periventricular. So are we dealing with a demyelinating disease like multiple sclerosis? I've already spoken out my reservations. So yes, I think as much as these symptoms have taken me close to multiple sclerosis, but I'm struggling to make that diagnosis because I do not see those features of separation in space and time. So I'll just say I do not have a diagnosis. I'm thinking the trigeminal nerve and probably the facial nerve are involved, but what is the exact pathology? Is it something vascular? We were not told if there are any features of ischemia in the area where the nuclei of these nerves are. Is it a demyelinating disease? I'm not sure. So let's just see the diagnosis, and I'll sit back and learn from you.
Sure. I think you had the diagnosis, but it's, yes, some things are just confusing on when the case went on to the exam and this imaging. But you got this very early in your discussion, and truly, as you thought initially, this case, let me tell you, it presented to my junior. Her name is Dr. Edna, and she thought of the diagnosis. When she told me, I I thought maybe it is not, and I thought it's a fascial nerve, maybe stuff. And we are the one who gave that pregabalin, but she came back again, no response. And then I had to, I just plugged the words uh, electric shock-like sensation in the up to date, and trigeminal neuralgia came up. So it was so easy for me. And so let me tell you what happened. So we stopped the pregabalin and we initiated this patient carbamazepine 200 milligram BID, which is the first line medication for this disease. And on the day that she came back, and then I ordered the MRI on that day that I initiated the med. So she came back 2 days later to take back the MRI results. Everything was gone. She could smile, no electric shock sensation, nothing. She was very fine. Even her blood pressure went back to normal. So I added junior aspirin because of that MRI. That is small vessel ischemic diseases, like they were incidental findings. We were not looking for them, and then we saw them. So I also initiated junior aspirin, but later on I read about the disease. Turned out junior aspirin doesn't help. When this patient will come back to clinic to withdraw it, it doesn't help in this disease. And then I added statins because of the hypercholesterolemia. So the atrophy might confuse you, but remember, it's 1 month. This patient was not using the right side because the moment she could chew on that side, it was terrible. So she opted not to use it. So it's disuse atrophy. And then the same applied when I told her to balloon. She ballooning is not a reflex. You choose to balloon or not. So she couldn't because I'm telling her, can you balloon the cheeks? She doesn't balloon on the right side because she's scared to trigger the electric shock. So she does it on the other side. So at least that's how I explain this disease. Plus, I didn't see anything on the MRI. But the point of ordering the MRI was if this trigeminal neuralgia is happening, it must be maybe compressed by something somewhere. That's why I wanted to see that thing, according to the literature. So let's see some learning points for this disease. Very interesting, very rare, but you see it, you make a diagnosis, patients are very happy because 1 month patient has been going around. So the way to present is as it was in this electric shock-like sensation on the face, And the most affected parts are V2, V3, the trigeminal supply. They are affected more than V1. This patient was V2, V3 affected. It's usually unilateral. And the triggers include touch, talking, chewing, washing, smiling, or wind, as she was saying. The etiology, most of the time, is compression of the nerve root, the trigeminal nerve root. And the things that can compress more and more, these are the vessels. And then other things that can do that include schwannomas or meningiomas. So that's the reason we are ordering an MRI to see. But again, even brainstem lesions can cause this. Luckily, they are not there. And others are idiopathic. So the epidem, this is a rare disease. Female are affected more than male. Age usually more than 50. And the risk include hypertension, migraine. Most of the things she had, she was a female, she was more than 50, she had hypertension. The imaging you order MRI, but the problem with this, my MRI is I couldn't specify the protocol. So if you order MRI, you also order plus MRI, but MRI is enough. But you specify the protocol. Should be high resolution MRI with thin cuts at the trigeminal ganglion. So, for example, this MRI is telling me there is nothing there. They didn't even comment about that ganglion. But I didn't tell them to cut thin section when they arrive at the trigeminal ganglion. And because I ordered the MRI from outside, so they don't see even my notes. And so treatment, carbamazepine works better than any other medications. But if they fail, you can add on gabapentin, lamotrigine, baclofen. And if there's no response to this, you do surgery of that ganglion. And so if these patients remain electric shock free for like 2 months, you taper down the meds and then you withdraw. You look when they will recur. When they will recur, you put back the meds. If they won't, then it's gone. Yeah, so it's a short case, David, and I wanted to share it with you. I think you were there like right on the start, and yeah, it's just a bit of things the exam that confused you, which is okay. You have to consider them. So very nice.
Thank you very much. Yes, I think this has been it's been a few minutes, but very intense. So first of all, I think those sensations, like I said right from the beginning, the only thing I knew at the beginning, of course, was with a presentation like this in someone who didn't have zoster before, then we wouldn't be talking about posthepatic neuralgia. It's trigeminal neuralgia. But then I think when we came to physical exam, because at the beginning I think that was the thing I was considering mostly. But then with physical exam, the issues of atrophy and then ballooning the cheeks, I think yes, those carried me away, and then I had to consider what else is going on here. Uh, but otherwise, I think I should thank you very much because it's been quite a learning experience. Because I think today I had to remind myself what slow thinking looks like. Uh, that was yes, that was a lot of slow thinking.
Yeah.
I had to remind myself and think out loud about so many things. So yes, it's been a good learning experience for me. And another thing, of course, although I know trigeminal neuralgia by name, I have not taken time to read about it in detail. So that's a gap that I think I have to go and fill.
Yeah.
And then these other things, they have added wisdom. So like the issue of atrophy on the right side, maybe just to go and look what else could explain something like this. But otherwise, I think I've collected a number of pearls that will be helpful if I encounter cases like these in the future. So thank you very much.
Thank you. Okay. Do we have any other thing from the audience? Any questions, additions? Anywhere we think I did wrong? Maybe you have any other idea? You're welcome.
Good evening, Dr. Joseph.
Yeah. Good evening, Seba. How are you?
I'm fine, Doctor.
Karibu.
Good evening, everyone.
Good evening, sir.
Yes, thank you, Dr. David, for a very nice flow through the presentation. I just had a quick shot just regarding of our patient presented. So I've seen there are some cases whereby patients with trigeminal neuralgia, it may be one of the possible early causes of early signs of patients with multiple sclerosis. So you may have the primary trigeminal neuralgia, which there is no any underlying cause sometimes, but you may have secondary, in which one of the possible causes may be multiple sclerosis. Now, seeing our patients in the brain MRI having a typical periventricular lesions, nodular periventricular lesions, these are one of the features which are very classic for multiple sclerosis. Now I was trying to look in the other pictures Dr. David was going through that possibly it might be a primary trigeminal neuralgia, but there is a possibility maybe that we are dealing with a secondary trigeminal neuralgia, which is possible secondary to multiple sclerosis, because as multiple sclerosis presents, usually the first presentation, usually it's a very mild form of a disease, which may only be trigeminal neuralgia, but it is pattern as it presents with remitting and relapsing pattern.
Sure.
Usually they have secondary progression. So a secondary progression, that is when they may have more severe symptoms such as the optic neuritis, even the transverse myelitis.
Sure.
So I'm not sure if our patient possibly may benefit from the screening. For example, if we perform the CSF oligoclonal bands for multiple sclerosis, because I know some of the labs, such as the Lancet, they do that. So maybe I'll pose the question to you, Dr. Joseph.
Very nice, Seba, and that's very good of you to think like that. So, yeah, that's true. But so two things. One, the epidemiology of MS. I think this has to be, for example, if this was maybe 22-year-old woman, that would have been number one. But again, yes, central nervous system lesions can explain that, but it has to explain this presentation of today. And the nucleus of the trigeminal nerve sits on all three areas of the brainstem, the midbrain, the pons, and the medulla. So they have to see a lesion there. So that lesion would explain today's presentation. But the one that we are seeing above, and the radiologist thinks, very experienced radiologist thinks is Fazeka 2, says that this has to be incidental findings, as maybe you are doing MRI for something else, and then you see they tell you Fazeka 2, which we have seen some other times. So if they would have told me that they are seeing a lesion on the nucleus of V2, V3 on the brainstem, that has to be followed up and investigated. You're saying that whether what we are seeing is just a second representation of something else. But they say the bulb was completely free of anything, no lesion there. So I think that makes me to think of idiopathic trigeminal neuralgia more than any other thing that is secondary. Am I making sense, Seba?
Yes, thank you, Doctor.
Yeah. Yeah, any other person? Nothing? Okay. David, do you have anything else?
Or nothing else. So just to thank everyone for joining. Very happy we had contributions from Seba. I think maybe what we need to remind ourselves is that we need to hear from everyone, so that will actually be more productive. Challenging, adding a different perspective. So like this one. So I believe because Joseph, you're in contact with this patient, you are treating them. So as you are seeing them for follow up, maybe you will also be watching very closely in order to see if they develop any other symptoms that point us in the direction of multiple sclerosis.
Yeah, sure.
Thank you very much, Seba, for the contribution. So, and I'd like to thank everyone for joining as always,
I see a
and to
hand.
remind you again that
I see a hand from Tom.
yes, Tom, there is a hand from Tom.
Yes, thank you for a very well explained case, scientifically explained. So for this patient complaining of the symptom that started just after throwing a stick to a cat, in our context, African context, that could be linked to many beliefs and probably leading to more psychological, probably psychogenic symptoms like she's presenting with. Maybe did we address it to make sure psychologically this doesn't happen again, probably?
Yeah, thank you for being for going so local. That's so nice. Yeah, so that was what she was believing. She was believing. Imagine the cat was black. So yeah, so I had to tell her that yeah, there is no relationship. It could have happened anyway. Yeah, so but that's nice. You manage things locally. We are all Tanzanian. We are all Africans. We know what we believe in.
Okay, thank you very much.
Yeah.
Actually, I had the same. So I thought definitely, and that's very important. Of course, if we need to manage our patients holistically,
Yeah.
that's not something you give a blind eye to.
Mm.
You do not just brush it off as okay, this is not important, because we have our communities have a lot of beliefs. So I think it's something that also needs to be addressed, that okay, this the symptoms that we see, there's something else that better explains it,
Yeah.
and not maybe something superstitious. So that's a very important point, Tom. Thank you very much.
Sure. Yeah. So
Yeah. So if there is no one else, we thank you very much for joining. If you have cases, we are still looking forward. I know Seba has presented a number of cases here, and I know he'll continue to do so in the future. But then we also wish to have someone else bring their case here in order to have inputs, because you can see, for example, today Joseph already made a diagnosis and the patient has improved, but then there are some inputs that I believe he will be watching out for any other symptoms in the patient. So if you have a case, even if it's not complete, just bring it so we can jog our problem solving skills, but at the same time helping the patients get better care. So thank you very much, and we hope to see you next weekend.
good night.
Good night.